Good morning, ladies and gentlemen. At the outset, I would like to assure you that I am going to finish my speech in 2 minutes. It's getting late. I have seen some of you looking at your watch. Secondly, after hearing Dr. Dangi and Mr. B.N.Singh and Dr. Shova Udapti, such a good, provocative, useful talk, I do not think that I will be able to talk much. But I wanted to come here. In fact, my name is not there in the list of the speakers also. But I definitely wanted to come here to thank Mr. S.N. Brahma, to appreciate the work of Mr. S.N. Brahma, Group President IJM and Pharma Business Technology, who is really doing a very important work for the service of the pharmaceutical industry. So much you have heard about the importance of pharmaceutical industry from important speakers you have heard since morning. I think this kind of, when he has organized this kind of seminar where eminent dietitians, eminent doctors are going to talk in the morning on importance of nutritional management, which is a very important area of pharmaceutical industry. It's really a useful cause. In the afternoon also, eminent marketeers are going to cover important subjects. So I really thank you, Mr. Brahma, for organizing this kind of seminar for the benefit of the participants. Secondly, I will fail in my duty if I will not speak a few words about my dear friend, Mr. B.N.Singh, who is also helping the industry in a big way. I really admire him. I am surprised. How does he give so much of time, whether it is for the cause of pharmaceutical industry, any function of I.A.Modi, whether it is a function of OPPI, Indian Pharmaceutical Congress, or this kind of function. You see, he is always available, he is giving time. He is a source of inspiration for us. And today, this morning, I do not know whether we have people from the press. The subjects you have taken up, I thank you for that, because that is the real problem of the industry. Indian manufacturers are willing to pay a very high salary because we need good professionals. I do not want to make a big claim. What you have heard about Alchem, it's not my contribution, or it is not the contribution of Mr. Sampradar Singh, who is our chairman, a very dynamic person, a great leader. It is our people, our managers, who are associated with Alchem or any organization, who really make the organization. And this is the high time. We have to think about the financial package. Another point is that today that trend is there, because we want you see, there may be at least 250 companies are there, of course big and small, and apart from that there are 12,000, 15,000 registered pharmaceutical companies. Some are registered, some are unregistered, which have brought the sale to the tune of around 25 crores, including of course bulk drug and export. And this turnover, the sale of pharmaceutical industry is going to be around 50,000 crores by the year 2005, 2006. Dr. Dangi, you are an expert. Do you agree with me?
It's not there to an extent. It's the size of the entire market.
Now, when the industry has to be a global player, that is a necessity, we have to invest in technology. We have to invest in manpower. In fact, we have to take care of our people. And believe me, the other day, I was talking to a professional. She is from England, and she worked for 4 years for Anvaxi. She had come here as a very senior manager. She came from Europe to have, she came to contact the pharmaceutical companies. And we were in a meeting privately. When I talked to her, I was so happy to hear that she has so much of respect for Dr. B.N.Singh, who is the real person behind the growth of vaccine, and she was talking about the vision, what kind of vision Dr. B.N.Singh had for vaccine, and today whatever technological improvement you find this great organization, or whatever improvement you see in export of vaccine, just now my friend Mr. B.N.Singh has talked about about Ranvaxi's performance or Dr. Reddy's performance. Now, I am talking about the emoluments. She was getting such a high package from Ranvaxi 4 years ago. Now she has joined an European company. The present chief executive of Ranvaxi is a man from England, if I am correct. What I am trying to say, we have to accept the importance of professionals. We have to work in a professional way. All of you know that Indian sector is far ahead of, Dr. Dangi will excuse me if I mention here, maybe it may be a little irrelevant, but the fact is that the contribution from Indian manufacturers is around 60%, or at least 55%. And there is a keen desire to grow. But the only problem is, on the one hand, the government is insisting that we have to go for we have to go for regulatory control. We must invest in our manufacturing facility. They are very keen that we have to take care of quality. True, we have to take care of quality. We have to give importance of GMP, good manufacturing practices. We have to go for automation. On the other hand, if there is this kind of rigorous price control, and this price, maybe today you heard that how much this treatment is becoming costly. Dr. Shubhadev Udapi spoke about this, but I can tell you, even today the price of medicine is the cheapest in the world, in India where the price is the cheapest. And this, one of the factors which has made price cheaper is the market competition. Anyway, I do not want to take much time. What I would like to emphasize here is that the future of pharmaceutical industry is bright. The professionals in any industry, and particularly in our pharmaceutical industry, are working in a focused way, are willing to grow. The youngsters have a very high ambition. They are doing very well outside India also. What is important is how we can work in a far better way. We have to, ladies and gentlemen, we have to keep in mind that we must increase our knowledge, and that is why this kind of discussion is important. I am sure all of you will be benefited by this discussion. I wish you all the best. I am sure this discussion in the morning as well as in the afternoon will be really very, very fruitful. Thank you very much. Sorry I have to do this.
Thank you, sir, for those stimulating words, and indeed the call for professionalism, integrated approach, I think is very relevant in today's scenario. Mr. Brahma would like to honor Mr. B.N.Singh. Thank you very much. And also Mr. Alva for being with us here this morning. Thank you very much, Mr. Alva. Time for a short break.
Dr. Ajit Jangi, Dr. Subha Udupi, Mr. B.N.Singh, and Mr. Alva for accepting my invitation and giving the presentations over here. And throughout the day, we are going to have series of presentations from the doctors, nutritionists, and the pharma marketing professionals. And most importantly, which I have been doing it since last 5 years, is the Pharma Business and Technology Excellence Awards. It has been recognized in the pharmaceutical industry as one of the kind, and no other magazines and any other publications group is giving this kind of comparisons. We have been giving this kind of award to late Dr. B.N.Singh, to D.B. Gupta of Lupin Laboratories Limited, and to many other professionals. We are going to felicitate the Pharma Business and Technology Prestigious Excellence Awards in 5-6 categories, and also on behalf of I.A.M. group of companies, I.A.M. will be privileging the renowned nutritionist for their remarkable and outstanding contributions in the field of diet and nutrition, which will be having, I'm expecting the Minister, the Union Minister of Health, Mr. Saturghun Sana, to join with us at 7 o'clock sharp. He's catching a flight there and he's reaching at 7 o'clock. He did call me in the morning. In fact, we'll have also having Mr. Kanvilkar also will be joining with us to confer the prestigious Pharma Business and Technology Excellence Awards and I.A.Modi Group's felicitations to the nutritionist. And I request all of you to be there for the whole day. Now, let us join us for tea and coffee. Thank you very much.
Just a minute, please wait. ते मागे आहेत ना त्यांना काढा दी. ओके सर. Once again. Thank you, sir.
So which journal is it I asked? Shobha, yes, I like the conclusion here. So I don't feel sorry.
वो बोल रहे थे डॉक्टर टांगी साहब को.
The first thing in India is that
एकदम sharp man बोलेगा. Otherwise, start at 9:30.
very well-known dietitian across the city of Bombay. She has been practicing as a dietitian for nearly 2 decades and has been associated with the Breach Candy Hospital and also the PJ Hinduja National Hospital. She was also a consulting dietitian for many years in various other capacities and now is a teaching faculty in the multinational companies and focuses to a large extent on dietitian and is a very well-known dietitian for the past 2 decades, as I mentioned earlier. I now request Mona Desai Mukadam to come over and moderate the symposium on New Millennium Nutritional Management, Dynamics and Dimensions.
Thank you very much, and a welcome once again to everybody after that very refreshing tea and coffee break that we had. I would like to welcome you all on behalf of the ID and the IGM, and without much further ado, I would like to call upon our very first speaker, Dr. Harish Bhende. Dr. Harish Bhende is a well-known orthopedic surgeon, and he is a consultant in joint replacement surgery at the Shushrusha Hospital and Dr. Lad's Hospital and also the Breach Candy Hospital. Apart from this, he's had multi experiences at working at different hospitals in the UK, in the US, Germany and Switzerland. Dr. Harish Bhende.
Hello. Can I have the caller mic? That is because of age, and the second one is rheumatoid arthritis. That is because of the inflammatory disease which happens at many times much younger age, and the people at very young age get disabled significantly. Restricting ourselves to the knee arthritis, the knee pain is very common in Indian, basically because we have a habit of squatting down. We sit cross-legged because of our social customs, and in spite of we living in a sunny country, we have a significant incidence of osteoporosis. I was just talking to the speaker who will be following me that we have got a very high incidence of osteoporosis, and Indian government has started a study to find out exactly how much incidence of osteoporosis is there in our country. And last but not the least, our diet in general is not very good in calcium. So we normally suffer a lack of calcium in the diet. And all these things ultimately translate into having person having arthritis with the increased chances of getting significant deformities and wear in the joint. The second aspect is we are now becoming more modern. The more people are living in the cities, we are becoming urbanized, and we normally tend to follow the sedentary lifestyle. We are becoming couch potatoes because we come back from home with a stressful life during the day, and at home all we have to do is switch on and start watching the television, eat a high caloric intake and just go to sleep. So all these things increase in the body weight, increase in a sedentary lifestyle,
plus the dietary lack of calcium, all these correspond to increased wear and tear in the knee joint, which is the main weight-bearing joint in the body. So the problem in these people who have arthritis is not just the pain, but they also have deformity. And when they get deformity, the body is unbalanced to walk, to locomote, to move. And this causes instability, and all these three together, pain, instability and deformity, ultimately reduce the function of a patient. Now, I would like to show you a picture of one of my patients who came to us. Now, this was a lady who had come to us about 6 years ago. She had a significant amount of arthritis, and because of arthritis, we advised her that she should undergo a surgery of knee replacement. As you know that when you talk about operation, people are normally afraid that, doctor, tell me anything, any medicine, any drugs, but I don't want to undergo operation. She kept on dragging on that for almost about 6 years, and when she came to me about 2 years ago, she had this deformity. This was a picture taken of us just before the operation in the operation table of operation theatre, and you can see how much deformity she had. Both knees were almost 90-degree bent. She was not able to walk more than just a household ambulation. She wasn't able to go out of the house, and she wasn't very old. She was just about 58-year-old, which I think is quite a young age for a person. Now, at this stage, there was no other option but to go ahead and do the operation. And we basically we had to do the replacement surgery at that time. After the operation, basically she improved quite a lot. Both the legs become straight. That is a picture of her after the surgery, and that is how she was walking after the operation. Both the legs had become straight. This is a picture taken roughly about 2 months after the second operation. These operations were done about a fortnight apart. Both the knees were straight. They were quite stable. And over a period of time, she has increased the flexibility in both the knees. She is now able to climb 2 stories down. She is able to go out independently. And the last time when she came to us, our clinic is on the 2nd floor, she could walk up instead of using the stairs or lift. So this is basically the importance of considering surgical options in people who are having severe deformed joints, and this happens because of arthritis. So when we talk about knee arthritis with the pain, deformity and instability, we basically have to consider what are the goals of our treatment. When a person comes with such a deformed joints, what we are talking about is not just doing an operation, but giving him a better quality of life, because basically we want the patient to be free of pain, if possible free of drugs, if possible improved functional ability to the normal self, and they should not have any disability. So these are the basically goals of the treatment, where patient we want to improve the quality of life. Now, what is the significance of this arthritis in Indian population? I normally give this mental arithmetic. I call it a rule of 10%. If you see, we are 1 billion Indians, and among them, suppose we are a young nation, so suppose 10% are above the age of 65, we still have about 100 million people above the age of 55, which can be, say, senior citizens. Among them, suppose 90% do not have any knee problem, which is not actually true, but sticking to the rule of 10%, that leaves 10 million people with arthritis of the knee joint. And normally 90% of the patient with arthritis can still be treated with medicine. They don't need surgery. That means almost about 1 million crippled people are there in the country, which having severely deformed joint require surgery. And the statistics about 3 years ago was 1700 surgeries were done per year in whole of India put together. And
I'm thankful to I.A.M. and IDA who had given me this opportunity to speak upon the vitamin D deficiency related osteomalacia. Next slide please. As everybody is knowing that vitamin D, calcium, phosphorus plays a major role in formation of bone. Vitamin D requirements are 5 to 10 micrograms per day. Mainly vitamin D is available through sun exposure. Only 1/10 of the daily requirement of vitamin D is taken through the diet. Milk, egg yolk, liver, butter are good sources of vitamin D. Next slide please. As I have stated earlier in the slide that sun exposure is the major source of the vitamin D. Few references how much sun exposure is required to have the adequate vitamin D is listed here. According to I.A.Modi, it is 5 minutes per day. According to D group, it is an efficient sun exposure of 2 hours per week of the face and hand. Algon et al. Each centimeter square of a skin, 6 international units of vitamin D is produced during each hour of exposure to the sunlight. According to Chara, exposure from 9 am to 3 pm 3 times a week for approximately 5 to 15 minutes is sufficient. Next slide. There is a various requirements has been listed in the literature. Few of them I have listed in these slides. According to ICMR, if you see the age group, less than 25 is 500 milligrams and above for women it has been recommended as 400 milligrams. As UK department has stated, it is 700 milligrams for the adult woman and teenagers are around 800 to 1000 milligrams. Next slide. According to ADA, the requirements are still higher is 1300 and as the age advances, the requirements are decreased to 1000. NIH has given the list of the requirements where they had distributed the woman into the postmenopausal and the menopausal woman, where if the person is on estrogen therapy, the requirement decreases to 1000 and if the lady is not on estrogen therapy, it increases to 1500. Next slide. 10 to 30% of the calcium in the average diet is absorbed. Fiber, phytate, oxalates initially thought to decrease the absorption, but the latest information is saying that according to ADA, Department of Health, UK Ministry of Agriculture do not have a significant effect on calcium intake overall. Protein and calcium plays a major role. High protein diet, especially animal protein, causes calcium loss. Calcium to protein ratio is very, very important, which is said to be 20:1. In one of the studies, the calcium loss was been measured and they found that on animal diet, the protein loss was 150 milligrams per day and a vegetable protein diet, it was only 103 milligrams per day. As we had stated that calcium and protein ratio is important, similarly the phosphorus is also important. Calcium to phosphorus ratio is very, very important and the ratio differs according to age. Adult it is 1:1 and children it is 1:1.5. Hence we decided to undertake a study of vitamin D deficiency related osteomalacia, keeping the aims and objectives as to evaluate the nutrient intake and compare with confirmed vitamin D deficiency related osteomalacia cases versus the normal population, to evaluate the bioavailability of calcium from the diet. In present study, 117 cases were included. In a study group, we had 47 cases versus control group was 70 cases. And data was analyzed statistically. Value of 0.05 was considered as statistically significant. We had given the statistics, whatever has been evaluated that. If you see the study group, most of the parameters, almost all the parameters were low compared to the control group and all the significance was also shown there. Next slide. If you see the ratios of calcium to protein, calcium to phosphorus ratio, which was not statistically significant, but if you see the ratios itself, there was a difference much more in the control group versus study group.
Yes, that was very enlightening. I now call upon our next speaker, Dr. Kaushal Pandey. Dr. Kaushal Pandey is one of our finest cardiovascular surgeons who has had extensive training in Australia and has headed the Department of Cardiac Surgery in Hinduja for the past 5 years. Sorry. During his 9.5-year tenure at Hinduja Hospital, he has performed over 6,000 cases and now does an amazing amount of 700 cases per year. Currently, he is attached to almost all the hospitals in Bombay, starting from Bombay Hospital to the Breach Candy, to the Harkisan Das, Kambala Hill, the Premchand and Kikabhai Hospital and the Bhatia Hospital. Dr. Kaushal Pandey.
Thank you, Mona, for the kind introduction. Good morning, ladies and gentlemen. We've been extremely busy operating day in and day out. And only last night at around 1 o'clock, I and my anesthetist decided to combine this talk. It's a very common subject to speak on, so we decided to collect the slides of last 3 years on the same topic that we have spoken, current innovations or current advances in cardiac surgery is one of the youngest specialties in the branch of surgery. Let's not forget that the first open heart surgery, the way it is performed today, was performed as recently as 1953. Everybody talks of coronary artery bypass surgery as if it's like an appendix operation, but the first coronary artery surgery was performed only in 1969, the year man landed on the moon. One thing about cardiac surgery is it's ever changing. So what we were performing 10 years ago is certainly not being performed today. And what I'm sure is being performed today or is the gold standard today doesn't remain so within 3 to 5 years. Since these slides are 2 or 3 years old, you will find that I'm using only the slide material to make a point. During the course of the talk, which is going to be a bit sketchy because I would have liked the talk to be in a story fashion, but since the compilation has been done late last night, I'm going to highlight 6 to 8 versions that have undergone change in the last 2 to 3 years, and I'll also make a point as to what's current and what's likely to happen in the next 3 to 4 years. One of the newer operations that we talk is the minimally invasive aortic valve surgery, wherein we perform aortic valve replacement using only a partial sternotomy. So instead of the patient having a full sternotomy where the breastbone is cut right from top to bottom, we either use the bottom half of the incision or only top half of the incision to expose the aortic valve, so which surgery can be performed with equal amount of safety. And I will illustrate a diagram and a picture of the patient later. Carbon dioxide is a very commonly available medical gas. We realized it was very useful for us to use it during valve surgery or any other surgery where any cardiac chamber was open. And basically carbon dioxide, being a highly soluble gas, is used by us for de-airing of the heart in surgeries involving opening up of cardiac chambers. Mid-cap or off-cap basically refers to minimally invasive coronary bypass surgery or beating heart coronary artery bypass surgery, which is the current fashion and which also is in evolution. And I will make a detailed mention of it in due course of my talk. I will certainly make a mention of gene therapy because that would be one subject where the pharma industry would be most interested in. As we go along, we also need to analyze whether all the new things that we are adopting are actually living up to our requirements, are actually living up to the gold standards already existing, and whether they have a future and whether we need to pursue with them. If somebody were to ask any cardiac surgeon what is one thing which has happened in the last 10 years and which is going to continue for another 10, would be the results of radial artery graft. Let's not forget, radial artery is one of the oldest grafts to be used. Radial arteries were used by cardiac surgeons as early as 1971 for constructing bypass grafts. But in 2 years' time, most surgeons, especially in France, realized that it wasn't standing up and that the results of radial artery were very, very inferior compared to vein grafts. And so the practice of radial artery as a conduit in coronary bypass operations was given up in 1975 itself.
Small token of appreciation. Our next speaker for the symposium is Gaurpriya Kopikar. She's Miss Gaurpriya Kopikar, who has been a practicing dietitian for the past 22 years. Out of these 22 years, 11 years she's been heading the Department of Dietetics at the Bombay Hospital, and she has also spent 11 years at the S.L. Raheja Hospital. She has a number of publications to her credit and is also actively involved in giving a lot of talks to the medical fraternity as well. Ms. Gaurpriya.
A very good afternoon to you all. This is the 900-bedded Bombay Hospital situated at New Marine Lines. We've had over 50 years of dedicated patient care, giving many patients the gift of life. Hippocrates has rightly said that food shall be thy remedy, and even founder father of ancient Indian medicine, Shushruta, has also ascertained that a disease can be controlled only by diet without medicines. One who doesn't take a controlled diet cannot be cured by even 100 medicines. Thus, dietary modifications plays a very pivotal key role in the management of cardiovascular diseases, and also there is no substitute for diet control. These are the glorious days of Mujhse Dosti Karoge, and this is exactly what our heart is telling us. Be my friend, adopt a heart-healthy life and adopt healthy eating patterns so that we can wish it a long and healthy life. In order that we should do this, what are the strategies that we have to adopt? Cholesterol, the nemesis of every health-conscious person. So what should we encourage our patients to eat in order that the bad LDL cholesterol and the elixir of life, the HDL cholesterol, we get the desired levels. Further, our mentality is always that we want to have khana pet bhar kar. Now this khana khazana that we want to eat, what cooking oil should be used and what are the foods that they should choose has to be dealt with. There are nowadays, because the housewives are working, even vegetables are cut and pre-packed, and on that they will write 0 cholesterol. I would like to draw your attention that only foods of animal origin have cholesterol, and we have to encourage our patients that instead of having whole milk, they have to have skim milk. Earlier, the housewife had to boil the milk, refrigerate it for 24 hours, then skim off the cream, and then use it for tea, coffee, curd, beverages, for milk. But now, Nestle has come out with slim milk, which is 0.5% fat, which can be used. Instead of having the whole egg, use 2 egg whites. Encourage the use of white fish and chicken without the skin. Instead of having the red and the cured textures, the cured meats like sausages, salami, have the textured vegetable proteins made from the protein soya isolate. Now, everybody, when you watch the TV, they are telling us fat is the main cause for the cardiovascular diseases. Everybody does surfing on the net and they know fat is the culprit, but they stubbornly continue doing so. They continue eating fat, and if any person sit down to having a meal, this is a balanced meal that you will see, but what do we see? In the center, we see one of the curries with a layer of oil. Now, fat, I agree, and all of you will agree that it is required for the contribution it gives regarding the palatability and the satiety of the food. But if you remember, our grandmothers used to tell us that I've made this dish with ghee, beta garam garam kha lena. Why? Because when it becomes cold, it coats the palate of your tongue, of the mouth, and food perception is lost. Food only absorbs the food flavors and it releases the food flavors. And therefore only a small quantity has to be used so that the flavors and spices that have been used we get the flavor of the food. If you have excess, it is lost. Therefore, when we take a cooking fat, what do we see? We nutritionists want to give only 20% of the total calories of fat. Further from this, because the saturated fat is it increases the HDL cholesterol, and it also the total cholesterol is increased, LDL is increased, we restrict it only to 6%. The polyunsaturated fatty acids, no doubt, reduce the total cholesterol, but at the same time, the elixir of life HDL is also reduced. So we restrict it to 4 to 6%. In this, N6 is only given as 3% and the N3 is only 0.3 to 1%. And we have to also consider if the N6 to N3 ratio is between 0 to 10. More than this, it will again reduce our HDL cholesterol. The monounsaturated fatty acids, yes, they are beneficial because they do not decrease the HDL cholesterol. So we give them up to 6 to 10% of the total calories. But when we are looking at the cooking oils which are available in the market, what do we look for? What is the saturated fats in them? What is the polyunsaturated fats? What is the ratio of N6 to N3? What is the monounsaturated fats? Now looking at the commonly used fats, what are available, the one which is saturated fats. Now ghee, the animal fat that all of us use is a ghee. If it's from buffalo's milk, then the N6 to N3 comes to 2.2, the saturated fat is 74, and the monounsaturates are 19. If it is from cow's milk, it will be, the ratio is 3.2, the monounsaturates are 25 and the saturates are 71. If we go to the vegetable oils, the one which is highest in having the N6 is the safflower, which is having 73, but the N3 is only 0.5, so the ratio is 146. The monounsaturates are there, again it is only 12. When you come to sunflower, the N6 is 49, the N3 is 0.3, the ratio is 163, even higher, but the monounsaturates there are 34. You come down to corn, the corn oil, the ratio of N6 to N3 is again 71, but the monounsaturates here are also 25.
Then what are the oils we have to use, because this is always a common controversy at most of the functions like this. Can we honor Lord Priya with a bouquet of flowers?
Kindly from introduction. At outset, I must thank Mr. Brahma. I think this is a wonderful opportunity. We orthopedic surgeons are always on the high of talking to selective audiences of orthopedic surgeons or general practitioners. Thank you, Brahma, for getting multi-speciality people right down here, together with good intermix of industry, dietitians, so that everyone can download. Is a key factor. Ignorance is a key factor. Nobody knows why some things are missed initially. Now no more they are. There has been enough education. Next. This is briefly the virology. I just said 1981 was the first case, and it came in form of Kaposi sarcoma. Friends, ours is a country where tuberculosis is very rampant, and we as surgeons face it in form of incurable or recurrences of tuberculosis of all kinds, whether it is from the spine, whether it is lymph node, or whether it is from the lung. So recurrence of tuberculosis is one of the most common way we face this problem. Next. Next. All this virology might sound little technical. All I can say is this is one of the weakest virus humanity has ever known. This virus, as you will see in the slides to come, can be killed even by hot water, by anything that would normally be resistant for virus as such. Next. So it is very fragile. 56 degree for 30 minutes can kill the virus. Most of the herbicides like sodium hypochlorite, calcium hypochlorite, ethanol, autoclaving for so long, and even a soap solution. So first, the scare is off because this virus can be easily killed. So if someone gets a cut and is nursing a patient who is known to have this problem, a good wash for good 10-15 minutes with either a specific solution or nothing is available, just by soap, will probably solve the problem there and there only. Next. This is what I said. Next. Now, this graph shows how a patient gets infected with AIDS. And we just said blood products. That is why hospital, where so many healthcare workers handle this blood secretions, gynecologists who conduct deliveries, breast milk, other body fluids. It directly acts as a conduit for passage into either mothers, from mothers to the child, or from sexual contact, and this is how you get the problem. this is important because it shows that we as a healthcare workers are in danger to be infected by. Next. Next. So this shows that first the virus gets into your system, goes to the lymph node, causes low immunity, and then slowly attacks and one after another paralyzes most of the body system. Incubation period. Once you know that you have been exposed to either through sexual contact or through stabs or through the secretion which I just said, it is as long as 7 years. Now, I will tell you a story. In 1991, I operated a case, a fractured spine with what we call as rodding the back. We did the case, patient recovered fully after that, and then we came to know that patient was strongly positive. Here is where my story starts today. We as the surgeons are endangered. We as the surgeons take Hippocratic oath that we cannot deny you treatment. And we as the surgeons are continuously under pressure to finish off the cases faster. How do we get out of this situation? That patient is now well, nothing has happened to him. There were no stab cuts to best of my knowledge during that surgery. Additionally, orthopedic surgeons handle what is called as a pointed wires. Now it is good 7 years and all of us in the team are thriving and operating. Question is whether we should have done testing of this patient at that point of time before deciding to operate. After knowing he's positive, whether we should have gone ahead and operated it, and what is the reaction of operating surgeons, healthcare workers, nurses who handle this patient day in and day out. We'll come to that short. Next.
To all of you, I take this opportunity to thank the organizers, particularly Dr. Niranjana Shah of the IDA Mumbai chapter and Mr. Brahma of the IGM group for giving me this opportunity to speak at this forum. The pandemic of AIDS, HIV/AIDS is here, and from all the projections of WHO, it seems that it's going to be a major problem in the coming 2 decades. Developing countries like ours are faced with a double burden. We are going to have the epidemics of the chronic degenerative diseases coupled with HIV infection, which poses a major challenge to all professionals in the field of health sciences. And that is where our role here as pharmacists, doctors, surgeons, nutritionists and dietitians is important and crucial, so that we play a vital role both in the control as well as management of the disease. First slide. Now this is something which all of us are aware of. HIV/AIDS acquired immunodeficiency syndrome, which results from infection by a retrovirus, which is the human immunodeficiency virus, which is characterized by progressive depletion of the CD4 cells, which was mentioned by Dr. Vaidya earlier. Next one. This leads to immunodeficiency, constitutional diseases, neurological complications, opportunistic infections, and neoplasms. Next one. Now, what is the relationship between HIV infection and nutrition? It's a dual relationship, actually, one affecting the other and having a synergistic effect. Now, optimum nutrition, we all know, is central to a competent immune system, which will maintain everybody's health. Nutritional status markedly influences the immunocompetence of any individual. And malnutrition and infection, even in a non-HIV situation, has a synergistic effect. And this is more so and magnified in a patient who is infected with HIV. Next one. The nutritional status affects the course of the disease. This has been documented in a number of studies. The disease in turn causes malnutrition. There is progressive weight loss and wasting. Now, the time period required for this whole process cannot be really predicted. It depends upon the course of the disease and the other interventions which are made available to the patient. Ultimately, there is severe protein energy malnutrition, which is a cardinal clinical manifestation of AIDS. Now, what exactly is the effect of HIV infection on the nutritional status of the patient? First of all, there is reduced food intake, which contributes to the malnutrition. There is anorexia, nausea, vomiting, dysphagia, oral lesions, esophageal lesions. The nausea and vomiting and anorexia can be caused also due to the drugs which he has to consume. CNS effects, the psychosocial effects, which are very bad because of the ostracization and alienation from the family, from the social environment which the person is living in. And of course, the economic factors. Especially in developing countries, this is a major problem because the drugs themselves are quite expensive, and then the resources available to the individual for food and diet becomes much less. And of course, his employment also is affected. Second factor which contributes to the malnutrition is the reduced absorption of the nutrients. Usually there is acute or chronic diarrhea, largely due to changes in the intestinal epithelium, the atrophy of the jejunum, and this results in severe malabsorption. So the person is not able to absorb even the small amount of nutrients which he or she may be consuming. And the third major factor is the increased utilization. The infection, usually the secondary infection followed by HIV infection, is associated with hypermetabolism. A lot of cytokine-mediated reactions occur, as a result of which the basal energy expenditure of the HIV-infected patient is elevated. And as a result of this hypermetabolic state, all nutrients, that is the macronutrients as well as the micronutrients, are utilized at a much faster rate. The turnover is very high. Next.
I must confess that I was extremely impressed with the title of the meeting, and that sort of prompted me to accept this invitation, which was very graciously offered to me. The nutritional management in the new millennium, the dimensions and the directions. I thought it was a very captivating kind of a title with very large and a broad base kind of a spectrum. And I was especially impressed with the topic which was chosen, and that is, if you would notice, it was type 2 diabetes in children and adolescents and not type 1, because I suppose we all are fairly familiar in terms of dealing with type 1 diabetes, but we need to sit back and take stock of the situation and realize that what we are going to now face is going to be type 2 diabetes and not really that much of type 1 diabetes in children. The next slide, please. Well, basically speaking, as I was just speaking to my next door neighbor of a colleague in this meeting right now, we all are constantly talking about type 1 diabetes in children, and in other words, what we commonly refer to as insulin-dependent diabetes in children, or insulin, they sort of require life sustenance through insulin. And what I'm trying to project today is the non-insulin dependent type of diabetes, which we commonly are used to thinking to be occurring only in adults, and I'd like to just draw your attention to the fact that that is the problem that we are going to face in children. Rather, we are already facing this problem in children and in adolescents now. But classically speaking, the non-insulin dependent diabetes in children is now emerging as a much higher problem in terms of its magnitude in comparison to the rest of the problems, which are very, very uncommon. The next slide, please. Well, really, how big a problem we are talking about? Are we talking about something just off the book which we have lifted off, or is it really happening in our practice? Is the first question which comes up to your mind whenever I sort of look at a new problem which I'm trying to read. Well, it's a very large problem, and if I was just to highlight the fact that this is the statistics which are available in the boys, and if you look at the 3 decades of statistics which are now available to us, it's progressively jumping up in its prevalence. And if you look at, in particular, this particular age group between 15 and 19 years, the prevalence rates are like something like 5 out of 100 children in this age group are going to have type 2 diabetes, and that's a very huge proportion of problem that we are talking about. We all are sort of fairly comfortable to understand the statistics of type 2 or a non-insulin diabetes in adults, which we talk about 5 to 7% of general population. And mind you, ladies and gentlemen, we're talking about literally the same amount of figures in children and adolescents, especially in this particular age group. The next slide, please. This problem is much larger actually in girls, and that too in girls between 15 and 19 years of age. It's almost 6 to 7% of girls in this particular age group, as you would see, in increasing frequency are getting affected with type 2 diabetes, given the fact which you are awailing through last 3 decades. The next slide, please. And why is this really on high? Basically speaking, all the risk factors as they are related to type 2 diabetes are in rise, and that in particular is addressing the fact related to increase in the prevalence of obesity. Coupled with this obesity is the price which we are paying for the civilization, and we have tremendous lack of physical activity, and this combination of obesity with lack of physical activity is absolutely potent to increase the prevalence of type 2 diabetes. The next slide, please. The known risk factors to our mind are predominantly based on the ethnic background. We can't do much about the genes or the ethnicity in which we are born, but we certainly can do something about the rest of the risk factors, which are predominantly obesity, the lack of physical activity, and of course the price that we are paying for the urbanization. The next slide, please. I think as audience at large, and just as a member of society in particular, we may have seen many girls, or especially during the phase of adolescence, who tend to have some degree of hair along the moustache line and along the beard line, and those are the typical patients of what we call as polycystic ovarian disease. Polycystic ovarian disease is actually speaking not a risk factor for diabetes, it's another form or manifestation of diabetes per se, because the basic pathology or the pathophysiology which governs these two disorders is literally the same. It's just the manifestations in the girls which tend to be different, in form of mainly related to the hair growth in a pattern which is more peculiar or particular to the males and not really to the females. And here when we try to look at the prevalence of impaired glucose tolerance, nearly 30% of these girls have impaired glucose tolerance, and anything from 7 to 14% of these girls have diabetes. These are extremely high and a staggering number of problems in terms of its magnitude that we are talking about. And that's, I think, what, if I can just achieve one fact today from this talk, is to sensitize this audience to say that the problem to come is going to be type 2 and not type 1 diabetes in children and adolescents. I think my part is done for the day. The next slide, please. Adults. It's basically the genes and the susceptibility with which we are born, and we can't do much about it. But we add to this the insult of our environment, which is what really produces the type 2 diabetes. The next slide, please. What really basically happens is there is a gross mismatch between the secretion or the amount of insulin which is produced in the body and what is really the effect of this insulin. Somewhere in this basic homeostasis, there is a loss of balance. There is insulin which is being produced is inactive, and larger amount of insulin cannot be now produced by the body. The result is going to be glucose homeostasis is going to be disturbed and upset. And though the initial ability, the initial problem is impaired action, ultimately it's the impaired secretion which is going to take over and give us what we find out from the laboratory in form of high blood sugars. The next slide, please.
Thank you, Dr. Nalinisha. That was very, very enlightening. May you accept a small token of our appreciation from Dr. Brahma. Yes, I know. And now we'll call upon our last speaker, Salome Benjamin, who has been a practicing dietitian for the past 25 years. She's the chief dietitian of the Nair Hospital and has included a lot of nutrition research and postgraduate teaching in her career. She has also several publications and presentations to her credit. Salome.
Good afternoon, everybody. Thank you, Mona, for kind introduction. Let me straight away go to my talk, as we are all very hungry. And my colleague, Dr. Nalini, has put forth the entire burden of the treatment part on a nutritionist. So let me begin. Let's start from taking diabetes to school. Next slide, please. Straight away going to the MNT therapy. Now, what is an MNT therapy? It is the government body, American Dietary Association, has placed this entire responsibility on a registered dietitian to have this medical nutrition therapy implemented to a patient suffering from diabetes, whether it be a child or it be an adult. And it's an integral part of the diabetes management, as we have already heard. And the most important is the adherence to the meal planning principles, and it's the most challenging aspect. And nutritional therapy is an essential component, as we have already heard. Next slide, please. Achieving nutrition-related goals requires a coordinated team effort. It's not only one person's job, it's a coordinated effort, including a diabetic child and the parents of the child. And because of the complexity of the issues, I have already told, the person who can give this therapy, the person should be registered dietitian, skilled in the and knowledgeable to implement this therapy to a child coming to her clinic. Next slide, please. She has already covered most of this, and as we see, all end with the nutrition therapy. Next, please. The rationale. Before I go over to the treatment, I would like to speak as we would look at the risk factors, among which the modifiable ones is obesity. A large number of obese children come to a dietitian's clinic, and therefore it is a greater responsibility to help them prevent for going into the diabetic condition. Next, please. As you all know, that there is a frightening increase also in inactivity in the children's life. We all see them going to school, going to tuition, coming back home, doing their homework, watching the television with a plate of snacks and going to bed. There is no time for activity. There is no schedule in the child's life where the child can do his or her normal activity or say a play, 1 hour's play. So I will go to the prevention part of it, which is more important. As we know, this is occurring in children, and there would a whole lot of life stretch forward before them. The best way to deal with type 2 DM is to prevent from developing in the first place. Counseling and motivation for a more active life, which is again MNT therapist's job, and improve eating habits, specifying that knock off empty calories, which I would say that in this current millennium where both the parents are working, our children are eating most of the junk food buying from outside, containing lot of empty calories, addition to increased weight. Adopting a healthier lifestyle, lose or maintain weight, set a goal and work together, making a subtle gradual change. Next slide, please. Nutritional related goal, as we say, growth and development is most important because they are children we are going to counsel, and they must grow to their best stature in the coming days. To improve glycemic control by balancing food intake with endogenous and exogenous levels. This way is part of a dietitian's job. How do you plan your meal plan? By balancing activity, nutrition and drugs to ensure optimum metabolic control. Type 2 DM, IGT or IFG, nutritional monitoring, weight management combined with physical activity may help to improve glycemic control and improve or maintain quality of life. Next slide, please. Assessment, as we have already seen, the anthropometric assessment we will do for every child, the BMI using the nomograms. Next please. Next, please. The waste is ratio, the most important assessment factor. Next, please. Yes, nutritional assessment, most important, which every MNT therapist should do for every child coming to the clinic. The recall using the food frequency table and the calculation of the intake. So we know where the child is going wrong and determining thereby the requirement of that particular child.
Sorry, we have to cut you short, but we are pushing for time right now. And Mr. Brahma, can we honor her with a small token of her appreciation? We will have a very small panel discussion now. It will be a short panel discussion for just about 15 minutes because I'm sure most of you are hypoglycemic by now. May I invite on the dais our esteemed panelists, Dr. S.V. Vaidya, Dr. Shastri, Dr. Anjali Mukherjee, Anjali Nair, Dr. Jagdeep Madan, and last but not the least, Dr. Subbalakshmi.
Discussion within 15 minutes time. But this is going to be a most debatable one. Whatever we discuss in the nutritional presentation and medical presentations is going to be debated, and I request all delegates, all dietitians, nutritionists, doctors and pharma companies to raise queries. In fact, the identity of the nutrition is at stake now. The profession of nutrition has been neglected so long, and this needs to be debated. And what is going to be the emerging role of nutritionist is a major concern for everybody. Unlike in often the Western countries, in Indian countries, the profession of nutrition has so far not been respected and recognized in the industry. This needs to be debated. And we can start the discussion right away from here now.
Is there
Hello, sorry, it's very late now. So I had one or two small questions sitting through the presentations, and one is that AIDS being such a big, wild, spreading disease, nobody touched upon, the group that talked about HIV did not touch upon the effect of breastfeeding. What is the incidence of infection in the breastfed children? Because we as nutritionists have been propagating that children have to be breastfed, and that has got so many advantages. Of course, Dr. Did mention about pregnancy and then went to the next one, but then I feel that we have to do a lot of work on this. How do we tackle with such a situation if the child is infected or not? Maybe you will be able to test, but if you are not able to test also, I think it is about 15% of the children who get through breastfeeding get infested.
I'll request Dr. Datta to answer this query now.
Ladies and gentlemen, this is a very intelligent point which has been raised by Madam. First of all, about the conference, since it is pertaining to the diet, and breastfeeding is being propagated at all the levels, especially in third world countries, where there is no substitute for mother milk, which all of us know. Especially in third world countries, the cause of death is PM, that is protein energy malnutrition, and mother's milk contains all sorts of ingredients which is required for the child's growth. As you rightly said, the parental transmission, that is the vertical transmission from mother to the offspring, is 33%. 33% of the women who are infected with HIV can transmit this infection to the newborn. About the diagnosis, whether the child has HIV or not, for first 5 years it is very debatable because the maternal antibodies are present, and only after the Western blot test, then later on it is decided. But as far as coming to the breastfeeding should be advocated at any cost, especially in a country like India, where we are living. There is no substitute to breastfeeding, because number of infections which take place by not feeding the child with by mother's milk may take place, and the mortality because of not breastfeeding is higher than breastfeeding. Thank you.
But in a similar situation, would you, you are saying that you cannot diagnose HIV in a neonate. But isn't it possible to test antigens like P24 and some other antigens, or don't we have it available over here?
This is again not very pertaining about P24 antigenemia or CD4 count as far as the newborn is concerned. But the only reason, because the maternal antibodies are present, and since there is a Western blot test which is come, or a PCR which is come, through that it will be possible to know. But still it is very debatable whether it will be possible to diagnose the child, the newborn, whether he is infected with HIV or he is not infected with HIV.
How do you justify the risk? It's a very definite risk. Your child is, you said 33% is significantly high incidence of vertical transmission. To justify this risk to the rest of the relatives is not very easy.
Anybody would like to answer that?
That maternal antibodies which are present in the child, they are persistent only about till 18 months. So if a child has antibodies after 18 months, it is a confirmed case of pediatric AIDS. And of course we do have P24 antigen testing in place, and we are doing, the government is having a prevention for mother to child transmission program in the 3 medical schools in the municipal corporation and in the JJ hospital, where the antenatal mothers are screened for the presence of HIV, and nevirapine is instituted to the positive mothers to prevent the mother to child transmission, and regular screening of P24 antigen even in the child, in a newborn child, as well as it is done at birth, and then it is done after 48 hours of birth in order to see whether the transmission has taken place in the child, and nevirapine is also instituted to the child. But when you're doing only an antibodies, then you have to see for the persistence of antibodies, say up to 18 months. And this is a program which is going on, and it is going to be also implemented in the peripheral hospitals of the Mumbai Municipal Corporation.
Well, may I ask this, may I take this opportunity to asking, since we are amidst all dietitians, nutritionists and doctors, can anybody answer me in the panel why the profession of diet and nutrition has been so far neglected, and why it has not been uplifted? And is the organizations, is there any organization which is taking steps to uplift the professions of diet and nutrition? Unlike in Western countries, it's been totally neglected out here now. The doctors don't require the nutritionist. And is it the cause that dietitians don't take this opportunity, they don't take this a platform to uplift the professions? Is there anybody who can answer the query?
I just like to make a comment here. I think it's heartening to see a platform wherein the nutritionist, the medical fraternity, the pharmacologist have come together. The very fact that we are together states that the status of a nutritionist definitely is uplifted today. Secondly, I think as nutritionists we read a lot.
Can I have some instances?
Sorry?
Can I have
No,
some
let me just complete what I want to say. We all read a lot, we all research a lot, but I think this is the time now to think of taking action. I think for a nutritionist, her success is to get results. We have to become accountable, responsible to what we are talking, to what we are doing. That is one thing. And from my personal experience, I feel everything works provided this implementation comes with a sense of understanding, because that understanding only a nutritionist as a counselor can provide, and the understanding provides you with conviction. And once you're convinced of something, you are bound to implement it. And once you implement, you get the results. And we as nutritionists should be role models as well as motivators for our own patients. We have to be models to instill that kind of spirit into our patients, to see that things are working, to see that we get results. We all know about the general guidelines, we all know about the foods to be emphasized, to be restricted. I think this is time now to put things into perspective and put it into action. Thank you.